हाँ तो साला कहाँ दोस्त को साला गायब मेरा। कहाँ भाई।
Hello. आनंद, गुड इवनिंग।
गुड इवनिंग सर।
डॉक्टर साहब ज्वाइन कर लिए?
नहीं, अभी नहीं ज्वाइन किए हैं।
अच्छा,
जी।
उनका जरा सीवी क्विकली भेजिए तो हमको।
ठीक ठीक।
आनंद,
जी सर।
डॉक्टर तिवारी will be joining shortly.
ओके सर।
He will do today's inauguration.
ओके सर।
हेलो।
Hi,
हेलो। हेलो।
good evening.
या गुड इवनिंग गुड इवनिंग।
I'm Dr. Ajay Sinha.
ओह अच्छा।
नमस्कार, नमस्कार।
नमस्ते।
नमस्कार नमस्कार।
Oh, sir, good evening, sir.
गुड इवनिंग गुड इवनिंग।
Dr. Tiwari is here.
So we are doing the short certificate course, and today is the day of cardiology. Dr. Ajay Kumar Sinha is here, master
Yes, yes.
teacher, and he will guide and explain about today's class. Dr. Sinha, please.
Good evening, sir. This has been a grand journey for us. Starting with a very small, like the first day, I started with the clinical journey of cardiology from A to Z, followed by a lot of top people in the field of cardiology like Soumitra Ray, and from Medanta Patna, Dr. Shraddha Ranjan, We had Dr. Asutosh, who's an electrophysiologist at Hyderabad.
Okay.
So he gave a journey of cardiac arrhythmia right from A to Z, almost everything. So those were, and we had attendance of, our students were like residents and students and PG students were almost like right from 60, 70 to 100.
Wonderful, sir.
Yeah, that has been, so sir requested you, Dr. Tiwari requested you to be a part of our journey of API Dean's PG program, which is solely carved out by Dr. Tiwari. His phenomenal vision has given us a lot of drive, and we are doing sixth of the series. Next would be Doctor from All India Shoot Patna uh, on heart failure. Probably, I have to confirm it. Sir has been instrumental in bringing out uh, this plan, and he is running this program in infectious disease, respiratory disease, endocrine and metabolism, and throughout you know, we are going through a phase of non-failing performance, and I would say that uh, he needs to be congratulated by all of us, the whole medical fraternity, I would say, because everybody is enjoying this
Yeah.
great event. Let me invite, sir, if you permit me, can I invite our guest speaker?
Yes, yes. You can
So,
go
our
ahead.
guest speaker, guest teacher, I would say, teacher, uh, in this series is Dr. Rahul Malhotra. He has been a phenomenal uh, professor, chief of non-invasive cardiology and clinical cardiology at Artemis Hospital, Gurugram. Uh, he has got a phenomenal journey of his education right from Jaipur to Delhi, and he's worked in almost every hospital of Delhi, every top hospital of Delhi. I was just going through his biodata. Uh, so, sir, today you're going to enlighten us with your knowledge on a little bit of non-invasive cardiology background and a little bit of introduction, followed by uh, treadmill test and echocardiography. That's
Yes.
what you have told us. So
Yes,
over
sir.
to you, sir. Over to you, sir.
So you can let me know when I can start. I'll be ready with the
Yeah,
presentation.
yeah. I think we can start
We
with your
can start.
permission, Dr. Tiwari.
Yes,
Sir,
you can start.
okay, okay. Sir, go ahead.
So good evening, everybody. I'm first of all thankful for the kind invite, for sharing the expertise, with, for the very kind introduction given by the very senior Professor Ajay Kumar. I've been visiting Patna early on for a monthly OPD, and then I've been visiting Muzaffarpur. So I have a fair impression of evaluation, and Patna has been far ahead of some other places, even in North India, which I happened to visit and got an idea about the level of cardiology being practiced. So I'm quite aware that there is substantial interest in good quality cardiology. And at the outset, let me tell the listeners that non-invasive cardiology, although this is a segregation into non-invasive and interventional nowadays, cardiology is not possible without non-invasive cardiology. And a thorough knowledge of non-invasive cardiology is an essential must for every clinician now. And although is this a very short period of time to summarize the two vast subjects of treadmill testing and echocardiography in one session, I will try to do justice to that. But please bear with me if, because of the paucity of time, I happen to rush through the slides and am not able to go into the nitty-gritty and the finer details of the two topics. I will try to present an overview and impress upon you the need of being thorough in these specialities, and the listeners are requested to refer to standard text for the finer details which they queries if they keep coming up with any questions during the presentation. We will have time for some questions, but this is just not possible to answer all the queries in this very vast topic. So with that, I begin the presentation. And firstly, I will be talking about treadmill testing, and then in the second half about echocardiography, again, very briefly. So are my slides visible, sir?
Yes, yes.
Am I audible?
Yes,
Yes.
you are audible and visible.
Thank you.
Quite okay.
So
Thank
let's begin with an introduction and a summary of treadmill testing. So treadmill test is a type of cardiac stress test. And what is a stress test? Stress test is based on the principle of utilizing different stressing modalities and checking the ability of the heart to respond to external stressors in a controlled clinical environment. So these are kind of provocative tests. And there are different types of stress tests available. The principle being we have a stressing modality and we have a response measuring modality. So we usually use two kinds of stressors. One is the exercise, the other is pharmacological stressors. And the response usually is measured in terms of increased heart rate, respiratory rate, systolic blood pressure, myocardial oxygen demand. This is the normal response expected of a healthy heart when exposed to different stressors. And if there is any abnormality, the heart is not able to withstand the stress, it will result in arrhythmia, myocardial ischemia, abnormal BP response in terms of hyper or hypotension, which we can always measure. So these are the principle of stress test. The stressing modality can be exercise, pharmacological, and the imaging modality with which we capture the response of the heart can be in the form of simple ECG tracings, imaging like by echocardiography or by nuclear imaging. And based on the combination of these stressors and imagers, we have a combination of stress test. Exercise ECG is what we call a treadmill test. Exercise echocardiography is what we call stress echocardiography. We can also combine exercise with nuclear imaging, stress perfusion imaging. Similarly, for the patients who are not able to exercise for some reason, we can subject them to pharmacological stressors, measure the ECG response, measure the echocardiographic response, or measure the perfusion response by perfusion imaging. So this has resulted in a different types of stress test modalities which we can use. Which test is the best? Which test is the most sensitive, most specific? Which test to use in which subject is a matter of great understanding. Not every patient is fit for every test, and not every test can be used for every subject. So this concept of ischemic cascade should be very well understood. As the degree of ischemia goes on increasing, the tests, depending on their sensitivity, will be able to pick up minor degrees of ischemia based on the sensitivity. So the most sensitive test going by the ischemic cascade is flow imaging modality or perfusion imaging modality, which will pick up the smallest degree of ischemia. And chest pain will be the last to occur when significant ischemia has already occurred. Similarly, ECG changes will occur when significant extent of ischemia has occurred, while wall motion on echo will occur much earlier before ECG changes. So thereby, stress perfusion imaging is a more sensitive modality than stress ECG imaging, which is treadmill testing. So this concept of ischemic cascade should be understood, usually not understood by patient, and they get confused why my one test was negative and the other test became positive. So the correct selection of test is very important. The types of exercise can be either dynamic or static. Most commonly used is upright treadmill exercise test, which is commonly available. commonly used. But as I like to tell my fellows, my physician colleagues, this is one of the least known tests today. We consider it to be very simple, very basic, but very often we come across greatly incorrect reports being interpreted. So as an MD physician, it is our paramount duty to at least understand the nitty-gritty of exercise electrocardiography very clearly and interpret this very simple and very widely available test correctly. So today I'll be talking about just this modality, exercise electrocardiography, layman's language very commonly known as treadmill test or the simple TMT. This is the basic equipment and setup required. It should be a spacious enough room, not a crowded or cramped room. Let us remember that this is a provocative test. 1 in 10,000 patients approximately can have a complication necessitating immediate cardiac resuscitation or shifting to a facility where at least CPR can be done, inotropes can be administered. So there should be good enough space, good enough room to shift out the patient and bring out the patient where resuscitative measures can be done. Otherwise, basic equipment like a BP monitor mounted in the wall, a treadmill, handrails available, a trained person in the vicinity, a physician in the vicinity should of course be there, and an infusion pump, pulse oximeter, a computer is a must have. There should be an exit strategy available in case a complication develops, and at least we say two to test, two people around to help should be there. Crash cart in the vicinity is of course of a great utility. Patient should be well instructed of about how the test will be conducted, what preparation should be had, and this slide briefly summarizes what all we should ask for the patients to do. Beta blockers commonly are stopped, but as I've emphasized, usually we need not to stop beta blockers. We may decrease the sensitivity of the test, but they increase the specificity of the test. For example, if the patient is on beta blockers and ends up having a clearly positive test, there is no doubt that the patient has classic ischemia and the test is not false positive. While if the patient has a negative test on beta blockers, we cannot be sure that if it is clearly negative. Probably if the patient has chest pain on beta blockers while the TMT is negative, it means that ischemia was not elicited and the patient has a false positive chest pain. Similarly, we should ask the patient to bring all the list of medications when coming from test, abstain from tobacco, alcohol, tea, coffee, at least 2 to 3 hours before the test is conducted. Similarly, we ask the patient to wear comfortable clothing, not grip the handrails very tightly. Let us know when they have chest pain developing, and not run but walk on the treadmill as the speed of the treadmill and the inclination of the treadmill increases. Several protocols are available. Each protocol has a different utility, different benefit, but the most widely used protocol, which is used for most patients, can be used comfortably, is the Bruce protocol, in which the inclination of the treadmill as well as the speed gradually increases after every 3 minutes. And the blood pressure and heart rate which we measure should be measured in the last 1 minute of each stage. So these are the stages, the grading, the speed of the treadmill, and metabolic equivalent. The greater the number of stages achieved by a patient in exercise, the better is the prognosis. We will see exercise treadmill, apart from having a good diagnostic value for myocardial ischemia, the commonest indication, also has great prognostic value. So if a patient has exercised quite well gone up to stage 4 and 5, the patient has excellent prognosis in terms of long-term probability of having cardiac events. Some definitions all of us should know. Metabolic equivalent, it is a measure of oxygen consumption per unit kg of body weight per minute. So 1 MET is equal to 3.4 ml of oxygen consumption per kg body weight per minute. This is the basic metabolic rate of the body in one way. The greater the METs consumed by exercise, the greater is the exercise capacity. And as I just mentioned, it is a good measure of the functional capacity of an individual. If a person is not even able to have 5 minutes on an exercise, the patient has poor exercise capacity, which also translates into poor prognosis in the long run. And persons achieving more than 6 minutes have significantly lower mortality rate as compared to those who cannot achieve this workload. So this is a very useful parameter to know. Just not focusing on STT changes, we can also come out with this information at the end of an exercise test. A few definitions all of us should be aware of: MPHR, THR, rate pressure product. Maximum predicted heart rate is calculated by the simple formula 220 minus age. Target heart rate is the 85% of MPHR, and a person should be able to achieve at least this target heart rate for the treadmill test to be interpretable for ischemia if there are no ECG changes produced. Rate pressure product is also a robust parameter of exercise capacity. Similarly, we use these terms in terms of submaximal study sometime when the peak heart rate achieved is below the maximum predicted heart rate. So this is a submaximal stress state, but adequate. It is inadequate if even 85% of MPHR is not achieved. So test cannot be relied upon for saying that the patient has no ischemia on stress test. We should achieve at least 85% of MPHR. We should have adequate stress test done for interpreting in terms of negative or positive for ischemia. Sometime non-diagnostic term is used when we say that the patient has not completed 85% of MPHR, then the test can be non-diagnostic because we can neither commit negative nor commit positive if no changes have developed, no symptoms have developed. A very important concept I would like all of us to know is pre-test probability of any test. So for treadmill test, pre-test probability is very important to know, and this is based on the Bayes theorem. So not all tests can be interpreted for all persons. It is very important to choose the right test for the right person. And very commonly nowadays we are seeing corporate health checkups are happening in most corporate laboratories or big health centers, where everybody, irrespective of their background, irrespective of their clinical scenario, their age, gender, is subjected to the same battery of tests. Everybody is getting a TMT done nowadays, end of March, because we have to submit our health reports. Even government setups are now demanding a health checkup. So if the pre-test probability is not right, so treadmill test, for example, has the best value when you choose treadmill test in an intermediate pre-test probability. If you have high pre-test probability of myocardial ischemia, for example, if we have a 70 years old gentleman complaining of significant chest discomfort when he walks for up to 1 kilometers every day, then this person need not to have a treadmill test done. He should directly go for a coronary angiogram because pre-test probability is quite high. We have a 30 years old sports person who runs regularly 10 kilometers and he is getting a corporate health checkup done. So pre-test probability is quite low. Again, if we subject him to treadmill test, the yield is likely to be incorrect. So the best result for detection of myocardial ischemia will be in intermediate pre-test probability, and there are several ways of assessing pre-test probability. Commonly, this is the three component pre-test probability chart which is used based on gender, classic angina, atypical angina, or non-anginal chest pain which the patient has, or dyspnea, and age. Based on this, if we decide clinically that the patient is an intermediate probability, then we should subject to treadmill test. Otherwise, the result will be inappropriate and we will not be able to interpret the test correctly. And these charts are available routinely in most textbooks. We can use any of these. And this is the ACC AHA, which I'm showing right now, which can be used, which is widely used. So based on this, with the rough rule of thumb also at the back of our mind, when we are sitting with a patient in the clinic, we know, for example, if a patient is less than 50 years of age, male or female, has non-anginal chest pain, then the probability is very low. We need not to subject them to a treadmill test. While if we have a 60 to 70 years old gentleman, although atypical chest discomfort, if we subject them to a treadmill test, it is likely to be best useful with coming out with a negative or a positive information regarding further testing for this particular patient. So this is how we should decide upon the utility of treadmill test in our patients. Moving on, some contraindication to exercise testing should be known. If we have decided to subject the patient to exercise testing, any acute event within the previous 2 weeks is an absolute contraindication. If the patient is having classical angina within 2 weeks, then it becomes unstable angina. We should not subject them. There is suspicion of infective endocarditis, symptomatic severe aortic stenosis if we have auscultated the patient, then these patients should not be subjected to exercise testing. If you are suspecting acute pulmonary embolism, acute myocarditis, again based on our clinical findings, then these should not be subjected to exercise test. A very important question when we get many patients who are subjected to TMT, their physicians have prescribed TMT without asking them about their ankle pains, their ability to exercise on a treadmill with increasing speed, their psychological status is not sound, they have balance issues. So all these patients should not be subjected to an exercise test on a treadmill. There are some relative contraindications which again will preclude the use of exercise testing for our patients. So once we have subjected the patient to exercise stress test, sometimes some parameters are looked at, pulse rate is looked at, exercise response in terms of heart rate is analyzed, blood pressure at the end of every stage is measured. All of them are important, but the most important parameter I'll quickly go through to, which is ECG changes, which we record during the treadmill testing. So these are the most important parameter considered for analysis of an exercise ECG result. But we should remember the sensitivity and specificity of a treadmill test is typically between 60 to 70% and 70 to 80% specificity. It's not very high. Compared to exercise imaging modality, the sensitivity specificity is both in 80s, 85, 85. So we should understand the sensitivity and specificity, which is intermediate for treadmill test. So when adjusted for referral or workup bias, it can vary greatly. So that is why the right selection of patient is very important. Very often we say that the TMT has been done, but we don't know still next test will still be required. Then the patient get disturbed that why did we do this test if you still are not sure about the outcome of the test, even after having made me run on a treadmill and I have subjected me to a treadmill test, I have spent money on this, even then you are not sure of the outcome. So a selection of the right patient is very important for this very useful test. It is not a useless test, but not very useful test also if the patient is not selected properly. Again, we get a lot of other information other than ECG information, positive, negative for ischemia. As I mentioned earlier, a lot of prognostic information is also obtained. Functional capacity is also obtained. Heart rate response is also not to be ignored when we are looking at a patient with treadmill test. So coming to the ECG changes, the classic response described is positive in terms of 1 millimeter, at least ST depression, which is horizontal or downsloping in 3 consecutive beats in any one lead is considered to be important. And this depression should be measured in context to the PQ point, which is the isoelectric point in the ECG tracing, which we also know as the J point. Again, we look at a point which is 60 to 80 millisecond away from the J point and then interpret. So not going theoretically, if you look at this image, PQ point is the isoelectric point here where my arrow is pointing. This is the J point and this is the J 80 millisecond. So what is the location of this point J80 in relation to the isoelectric point. In this image, it is elevated. A stress test is interpreted based on the location of this J80 and the J point in relation to the isoelectric point. If you look at this image, here in this second image, the J80 J point is down, but the J80 point has come up to the baseline. So this is negative. Out in the third image, we see that the J point has also gone down in relation to the isoelectric point, and the J80 has also remained below the isoelectric line, which means that this is a positive response, and we will interpret this as at least 1 millimeter ST segment depression. There can be horizontal ST segment depression similarly, and there can be a downsloping ST segment depression also. So this is very important to understand. This is how we interpret the ST segment. ST segment is a long segment, but we take J80 as the representative of the entire ST segment and interpret it based on the location of this J80. Very often we come across very incorrectly interpreted treadmill test, patient referred from the invasive angiography, when in fact routinely we find that they do not need angiogram because a treadmill test has been wrongly interpreted based on other locations of the ST segment. There can be different types of ST depression based on this, and this becomes a lot of confusing, but it is quite simple if we sit down and interpret. As I just mentioned, as a physician, it is our duty to at least interpret a treadmill test correctly. And these are the basics of ST depression, T wave inversion interpretation. I do not have time in this single presentation to go into the details of all this, but you can see the classic criteria for interpretation is what we just saw. J point and J80, 80 millisecond away from J point, both are depressed by at least 1 millimeter below the isoelectric point, then it is to be interpreted as clearly positive. If it is downsloping or horizontal, then that is the second point we should mention, looking at the slope of the ST segment. So this is how we interpret. Other minor criteria are ST segment elevation, which are also important. We won't go into the nitty-gritty of that, but just please remember that lateral precordial leads are the best for interpretation. V5 alone is the most important. Commonly, we see changes in second, third, and AVF leads, which are least specific. They are usually falsely positive, but even if we find positive in them, we have to interpret it as positive. The greater the number of leads positive, the greater the chances of the treadmill test being clearly positive. Similarly, early normalization of changes in recovery is less likely to be significant, while the patient is likely to have better prognosis. If the changes persist up to 5 minutes of recovery, the patient likely has multivessel disease and likely to have severe disease. So based on these combination of leads, how many leads are positive, till what duration the ST segment remains depressed, how much the ST segment goes down, 3 millimeter or more down, downsloping slope, recovery after 5 minutes, all these point towards significantly positive and multivessel disease or left main disease. ST segment elevation in any lead other than AVR is clearly to be treated as positive, which is likely to be interpreted as having a multivessel disease or a patient with a left main disease. Upsloping ST depression is slightly contentious issue, not clearly defined, so generally not treated as positive. But one thing we should remember is that when we interpret ECG changes in a treadmill test, we should not interpret it in terms of coronary arteries. If the patient has ST depression in 2-3 AVF, we should not call it as inferior wall ischemia, because this will not be correct. When you do coronary angiogram, the patient will turn out to have either LAD or LCX or even RCS. So Vessel localization is not possible by TMT. This should be remembered. Changes in QRS duration happen during TMT. We should be aware. Normally the QRS narrows down, but sometimes we get bundle branch block which develops during treadmill test. This is not very important. If it occurs at a higher exercise rate, you need to mention it into your report and not interpret it as positive or negative in terms of ischemia. Some co-confounders in exercise test interpretation. Again, if we have taken properly the history, we should not subject these patients to a treadmill test because we will not be able to interpret the treadmill test. You may be a master cardiologist, but you will not be able to interpret. This is likely to be a big confounder. If a patient is on digoxin, has significant left ventricular hypertrophy on a resting ECG, already has ST depression on ECG with a left bundle branch block, then the test becomes uninterpretable. You will not be able to interpret. The patient has significant bradycardia on the beta blockers. So you will have exercise heart rate not reaching up to 85%. And then again, you will be sitting with a negative response, which you cannot confidently report as negative also. So these are the confounders where exercise tests should not be done because we will not have any interpretation and patient will be annoyed that having paid so much money, still we are not having any result. So other than ischemia, ECG stress test is very useful prognostically also. As I mentioned, the most important prognostic marker is not ECG ST segment changes, but functional capacity. If a person is able to exercise on a treadmill in your neighborhood, in your department, you yourself, if you are able to exercise up to stage 4, I do not know your body weight. I do not know your background of coronary artery disease, or you may have stenting done, you may have had bypass done. Still, your prognosis is better than a person who is not able to accomplish this much exercise capacity on a treadmill test. So it is an excellent prognostic marker of exercise capacity and cardiac events in the future. So we have several other prognostic markers also given, and we have several risk scores defined based on a combination of parameters that you achieve on a treadmill score. Commonly in our labs, we report a Duke treadmill score, which is a combination of the angina which the patient developed during the treadmill exercise, the degree of STT changes the patients develop, and what was the duration of exercise. So based on this, we have a formula: the exercise time minus 5 times ST deviation minus 4 times angina index from this angina score 1 or 2, limiting angina. And if we put this, a Duke treadmill score is given, and based on Duke treadmill score, there are clear prognostic scale which has been given and which can predict very accurately what is the prognosis of the patient in the future. A word about treadmill test in women. Women very commonly have false positive treadmill test. So we should be very careful in using a treadmill test in women if they already have resting ECG changes or if the pre-test probability is not correct. So based on this, we should probably choose a echocardiography based test rather than a ECG interpretation based test because they commonly have false positive ECG changes in them. So to end this presentation, how to proceed after a stress test based on ECG or the TMT has been done. If the patient already had an intermediate CAD risk, if we chose exercise treadmill test strategy, then if the patient had a clearly positive test, then we should subject the patient to coronary imaging directly. If the patient still had intermediate test, then the imaging modality should be the next test, which will help us decide. Very commonly, we get across patients who have a positive test reported, and clinically, we feel that the patient is likely to have a false positive treadmill test. Then we subject the patient to a stress imaging modality. And then, if the patient has clearly positive imaging modality test, then the patient is subjected to coronary angiogram. If the stress imaging, for example, stress echo turns out to be negative, then no need of further testing because these are very high specificity and the patient can directly be taken on medical therapy only, no need of coronary angiogram. So with this, I will end this presentation of treadmill testing. I apologize for the speed of presentation because it is not possible to cover this vast topic in this short period of time. But I would request you to park your questions for the time being, for the end of the presentation. And I move quickly to the next part, which is echocardiography. So again, echocardiography is a big topic in itself, and I will be giving you an overview of the role of currently the role of echocardiography in clinical practice. As a head of an institution where we require non-invasive cardiology, and we are short of people uh, doing non-invasive echocardiography properly, and we are looking for people who can be interpreting these tests correctly, doing these tests correctly. I'll just try to emphasize the increasing role of echocardiography. As has happened in the modern times, we all the people in terms of cardiology are running after interventions, and we often ignore and undermine the value of non-invasive modalities like ECG, treadmill test, chest X-ray, and echocardiography. So I hope I'll be able to impress upon you the great value and in fact the greatly increasing value of echocardiography in the current era. Echocardiography is the most commonly used non-invasive modality in cardiology now. It is non-invasive, extremely safe, very versatile, highly portable. In fact, we can go to any corner of the hospital even today. It can be done at the bedside, in the OPD, in the emergency room, in the operation theater, in the cath lab, and even in the ambulance in emergencies. We've done that in our patients. So extremely safe, extremely versatile, and in our country, quite low cost, widely available, can be done the same day. Reports are available within half an hour of completion of the test. And this is not possible for any other modality. I keep impressing upon people that even an ultrasound or a CT scan or an MRI, the reports or the results are not so rapidly available as they are with echocardiogram. So these are the machines, big sized machines, laptop based portable machines, and a handheld echocardiography machines, which are available for use in the emergency rooms, which we have been using. There are different probes which are available, a simple probe with 1-inch footprint, which can do all the work for us, including 2D, 3D, strain, myocardial deformation index, work, everything can be done by these probes, but different probes are available. We should be aware of which probes to use for which modality. This is a transesophageal echo probe. Again, a very small footprint, 1-inch, which goes in the esophagus from right behind the heart. It can give us very precise and very accurate imaging. So what is echocardiography? So echocardiography is often confused because we get so clear images of the heart that we think that it is actually imaging of the heart, which is not true. Echocardiography is make believe. I often say that because echocardiography is an image which is reconstructed by the software of the machine based on the ultrasound images it receives after the ultrasound is sent from the transducer piezoelectric crystal inside the body. So once the ultrasound beam is sent from the transducer inside the body to the heart, it undergoes a lot of changes. Some energy is absorbed, some is reflected back, some is refracted, and the machine, based on the information it receives back, thinks about the information received and then reconstructs an image. So a lot of artifacts are also formed in the echocardiography image, and often many things are not seen which are clearly there, and many things which are not there are seen clearly when you see an echo image. So do not believe in your echo image. Sometimes there can be very clear artifacts which the best of people cannot interpret. So be very careful on interpreting your echocardiography images. So what is an echo image? For that, when you have an echo image being formed, it goes through a lot of modification in the ultrasound machine or the echocardio machine. The old time machines had this rotating motion in the probe. The older cardiologists will recognize this. We had a motor in the probe which used to make the beam move from left to right. But now electronic beam steering is done and the image is made to move from left to right without moving the probe or the motor inside the probe. And then we have an image which is made in a 2D echo. We have an image which is made of several frames. So we call these beams, and several beams, when they are put together, the machine makes one frame. And when the machine moves several frames very quickly in one cardiac cycle, several frames in different parts of the cardiac cycle, the acquired frames in different parts of the cardiac cycle are put together and they are represented as a moving clip. We call it a cine image. So this is a one moving clip, which is a combination of multiple frames. So these are the terms we often use: frame rate, frames, beams. So this is how they are formed, and we should be aware of these words when we use in echocardiography. Now 3D echo is widely available, and the depth perception also happens in 3D echo. So real-time three-dimensional echo, which is also now known as 4D echo, is available, which also gives us a depth perception. So instead of a sectoral data set, we get a pyramidal data set which is formed. So this is how image is formed by the machine. Ultrasound image is transmitted. It strikes the objects in the chest, including the heart, blood, comes back. Reflected wave is analyzed in terms of how much time it took, how much modification it has undergone, and the software in the machine comes out with an image in different formats. And we can use this in different modes in terms of different interpretations. So I'll tell you what terms we have been using commonly when we interpret these images. And based on this, we have different types of routes. So when we say echocardiography route, transthoracic echocardiography, transthoracic route, transesophageal route, we can also image from inside the heart, intravascular ultrasound, and we can even go in the heart chambers. We call it intracardiac echo. IVUS is now routinely used in cardiac intervention, while intracardiac echo is now slowly becoming available as we do cardiac interventions guided by echo. This is the commonest that we know, transthoracic echo, where we image the heart from in between the ribs, where an echo window is available for looking at the heart. This is the position of the patient, the position of the echocardiographer, the position of the machine, and we are able to get images immediately. Transesophageal echo, we insert an esophageal probe which goes very closely behind the left atrium in the heart, because esophagus is almost abutting left atrium behind the heart. So when we do this transesophageal echocardiography, very useful for left atrium, mitral valve, the posterior structures of the heart, very accurate imaging is possible. IVUS, as I mentioned, is routinely being used in cardiac interventions now, and intracardiac echo is slowly becoming available to us now. We need to learn the kind of images that you get by eyes, but it has its own limitation of expense, fresh training required. So other terms used in echocardiography is modalities. When we do an echocardiogram, we have all these modalities available in our machine, which we can use in all studies. M mode echo, 2D echo, pulse wave Doppler, continuous wave Doppler, color Doppler, tissue Doppler, strain imaging, three-dimensional echo, and stress echo or contrast echo. So very often we get requests for 2D echo or only 3D echo or echo Doppler. So these are missed terms which we should avoid using. Echocardiography with different modalities, all of these modalities are usually aware with the softwares on a machine, and we can do this. For example, a basic 2D echo machine will have everything from M mode, 2D echo, pulse wave, color Doppler, continuous wave Doppler, and tissue Doppler. Strain 3D softwares may or may not be there, but all these modalities will be there on all basic 2D echo machines. This is the utility of an M mode, and you should use these modalities accordingly in all patients. Not any of these modalities is useless, all modalities are useful. This is an example of an M mode echo, which is the first modality we started using in 1960s and 70s. Even now, in appropriate settings, we use M mode, which is very useful for different scenarios. Here we are showing M mode through an aortic valve. We can see mid-systolic closure of the aortic valve, fluttering of the aortic valve, which clearly points that this patient has hypertrophic cardiomyopathy. So just by one M mode image, we have been able to diagnose hypertrophic cardiomyopathy. 2D echo is a slice imaging. Like when we get this 4-chamber view of the heart in 2D echo, it is a thin 1 centimeter slide of the heart which is made by the machine, based on which we interpret. So this is what we should remember and not forget, that this is a thin slice. When we do Doppler imaging, Doppler is looking at the movement of the red blood cells in the heart, utilizing the Doppler principle, which says that if the RBCs are moving towards the heart, they will be measured as having higher velocities, while if the RBCs are moving away from the transducer, they will be shown to have a lesser velocity than the transmitted velocity of the ultrasound transducer, and the machine will be able to interpret this shift in the velocity of RBC as whether the RBCs are moving towards or away. And this Doppler equation 2V of cos theta is utilized by the software of the machine, and it is able to give us the accurate velocity of the red blood cells, which means the velocity of the blood in the heart. And we very smartly are able to use this for different purposes. This is, for example, very commonly used mitral inflow velocity measured at the tips of mitral leaflets, used for assessment of the diastolic function of the heart. Similarly, we can also have continuous wave Doppler utilized, which will give us in a single frame. I have chosen this slide. We have a patient of aortic stenosis. We did continuous wave Doppler across the aortic valve. So just by this single continuous wave Doppler, we got all these parameters. And we can see the mean gradient is 93 millimeters mercury. So this patient has clearly severe aortic stenosis, because mean gradient above 40 millimeters is severe aortic stenosis. We also can see measure pressure half time of this aortic regurgitation velocity in the same single image, and based on pressure half time, which is 336 milliseconds, we know that the patient has aortic regurgitation which is not severe, probably moderate. So in one image, we have been able to diagnose severe aortic stenosis, moderate aortic regurgitation by utility of continuous wave Doppler. Very simple, very straightforward, no side effect to the patient, very short time, and no CT, no MRI, no angiogram is required for doing this kind of diagnosis. Single image, all the information very accurately. Although we should be doing other ancillary tests to confirm severe aortic stenosis by echo, we need to do certain other parameters like chamber dimensions also, but just showing the utility of this remarkable tool. Similarly, we can measure the velocity of the tissues in the heart. So annular tissue Doppler, which has utility in different types of diseases. Stress echo is done. We have just seen stress ECG, which is TMT. A better test is stress echocardiography, more sensitive, more specific for interpreting coronary artery disease. We routinely do this and interpret whether the patient has coronary artery disease or not. You can see there was no wall motion abnormality. Gradually at low dose dobutamine and peak dose dobutamine, we can see contractility has increased. No wall motion developed, and the patient is in recovery. Again, this is a negative stress test. 3D echo is now available widely. We are doing 3D echo, which gives us very clear images We can analyze the depth of the heart also. And rather than just imaging in slices, we can see as pyramid and clear images of the heart. You can see there is a patient with ventricular septal rupture seen, which could have been missed on a slice imaging on 2D echo. This patient below has mitral stenosis. This is a transesophageal echo of the mitral valve. We call it the surgeon's view. And we are able to see this within a second of starting our transesophageal echo. The entire mitral apparatus, the aortic valve, the left atrial appendage clearly seen, and we know that the commissures are fused here. The patient has significant mitral stenosis. Strain imaging is now available widely, is being used for interpretation of different diseases. There is no, I often say this in our echo lab, in today's day and age, if we report echo without strain imaging, we are living in an era of black and white television. So useful it has become in a very short period of time. For example, we may have ejection fraction of 55 to 60% in a patient of, say, undergoing chemotherapy. But if the strain is less, even though the EF may be normal, the patient has had significant myocardial injury already, and we have lost significant myocardium if the strain has deranged. It is very sensitive compared to ejection fraction for looking at myocardial systolic function. So strain should be reported in most patients nowadays, wherever it is required. Patients of heart failure, patients of valvular heart disease, patient undergoing chemotherapy for cardiotoxic chemotherapeutic agent, etc. Torsion, etc. I need not to go into details. These are further imaging modalities which are increasingly being aware with the software in the latest machines. Contrast echo, it is not currently available in our country, but we used to use it. It is expensive, but we can use it where it is very necessary to have good quality cardiac imaging, and no other modality is possible. So I'll summarize. The utility of echocardiography is great. It tells us about the structure of the heart, about the function of the heart, about the valves, about the pericardium, the aorta, the main pulmonary artery. We can pick up diseases with great ease, great safety, great accuracy. Need not subject our patient to expensive tests with radiation and make them travel to far distances for tests, which most of the things, if they could have been diagnosed or ruled out by properly done non-invasive imaging. These are examples of cardiac size, which can accurately be measured by echocardiography. Volumes can now be assessed very clearly by three-dimensional echo, which is now the gold standard for ejection fraction. Or this kind of an LV volume, you can see end diastolic volume, end systolic volume, ejection fraction, stroke volume, and quite accurately possible within less than a minute by three-dimensional echo with the use of the softwares that are available now. And who all requires echocardiography? In our hospital, I can tell you it is not just cardiologists. A routine day, we do echocardiograms for cardiology, different indications, coronary artery disease, valvular artery disease, congenital tumors, myxomas picked up, thrombus in the heart, but also from other departments like oncology. If the patient is on, for example, Herceptin for CA breast, before and after and throughout the chemotherapy, every 3 weeks, 3 months, they will be sending them to us for looking at cardiotoxicity by chemotherapeutic agents, which is now the commonest cause of death other than cancer itself. Nephrology patients undergoing transplants being worked up, neurology patients, rheumatology patients like scleroderma, if they want to rule out pulmonary hypertension, they send them to us routinely for an echocardiograph. Even liver transplant team with a patient undergoing liver transplant, desaturating, they want to know if the hepatopulmonary shunting is happening, and we have to do bubble contrast study. So the utility of echocardiography is great. We should not undermine and underestimate this value and utilize this very useful test appropriately. So again, with this, I end this presentation. I apologize for rushing through the slides in the interest of time. And if we have time, I request Dr. Sinha to please take any questions if we have now.
Thank you. Thank you very much, sir. Uh,
Sir, I would like to interpret you briefly and request you not to address me as sir. I am very junior to you and very young.
no problem. Uh, Never mind. Uh, See, somebody asked about the books. Can you tell them about the books which they should study to begin with on echocardiography? Like,
Okay, wonderful.
yeah,
So, sir, I say the best student is the best teacher is experience. So we should, if you have echocardiography machine at your place, start doing it. Start grabbing the probe. Start making images, and simultaneously keep learning. Both go hand in hand. We say that it is like a sailor knowing everything about the sea by reading books but never going to the sea, and the other thing is jumping in the sea not knowing how to swim. So
yeah.
both are required simultaneously. Regarding textbooks, I recommend usually clinical echocardiography by Catherine Otto or Jamil Tajik, but Catherine Otto is more systematic, simple to lay your hands. We also have an Indian Academy of Echocardiography textbook, which we had released a few years ago. I'd been a secretary of Indian Echocardiography for 2 terms and a treasurer for 2 terms prior to that. So I'll recommend any of these 2 books, starting with Indian Academy of Echo will be better, and Clinical Echo by Otto in the background will be useful. Secondly, I would like you to attend workshops on echo in the annual conferences or workshops on echo wherever they are happening to brush up your knowledge, resolve your queries, whatever they are, whenever you get an opportunity.
Somebody is asking about, the question is that who can do echo? Can an MD medicine do echo and report?
A very good question, sir. This is as per PNDT Act. Yes, MD medicine is permitted to do echo and report.
Yeah, and best way to learn echo, you have already emphasized this very well, that best way to learn echo is to have a machine. And with the background knowledge of theoretical knowledge, you start working with a little person, mentor like you. And I think you will learn the art and science of very well. Uh, so, what about just MBBS? Somebody asked about this question. Mohammad Abdul Aziz has asked a question like, what about just MBBS? Can he do echo?
Sir, as per PCP regarding who can do echo. So I will leave that topic for now because this is a very contentious issue. There is no clear definition of who can do an echo as per the PCPNDT Act. Having said that, I will request you to post questions about the echocardiography topic itself rather than the law.
Yeah. So it was all very good. Any other question from our colleagues, from our students on treadmill test, stress test, or echocardiography? Echo fellowship, somebody asked about the echo fellowship. I'm sure the fellowship in echocardiography has been too many.
Yes, sir.
It
And
can,
if anybody is interested, I welcome you to visit our center.
yeah,
We have been advertising and we are open to doing at least a 1 year fellowship in non-invasive cardiology,
yeah,
which includes not just echocardiography, but other nuances like treadmill testing, ambulatory blood pressure,
yeah,
ECG interpretation, etc. at our center.
yeah. Regarding the localizing value, I have a humble submission
Sir.
that can ST elevation of during the stress localize a site.
Correctly said, sir. ST depression is not useful for localizing, but ST elevation in non-Q leads is known to localize the vessel. This is correct.
So any other question? Uh, uh, so somebody has commented, it was a wonderful session.
Thank
Dr.
you.
Mohammed Abdul Aziz. So
Thank you.
thank you, Aziz. I wish you a very good career in cardiology. Yeah. Somebody has put a question on EA ratio. Dr. Yasmin, can you
So, yes,
highlight this?
EA ratio is part of assessment of the diastolic function of the heart. As I briefly showed in the Doppler image, we measure it with pulse Doppler at the tips of the mitral leaflets, measure the A wave velocity, E wave velocity, and even now it is helps us very useful in assessing the diastolic dysfunction in all the patients. So they are usually mentioned in all echo reports.
Any use of bubble contrast? This is my humble submission to you. Any role of bubble contrast, which is a poor man's contrast?
Yes, sir. So we still do bubble contrast at least once in a week. We get a request, particularly from the hepatopulmonary shunting point of view. From the cirrhotic patients, the liver transplant team or the gastroenterologist ask for it. The patient is significantly breathless or desaturating. We do bubble contrast. The other is when we find a dilated coronary sinus on echo, we suspect persistent left superior vena cava. We use bubble contrast routinely. In a PFO setting, a cryptogenic stroke, the neurology team is very commonly referring us for transesophageal echo. Young patients with stroke where no other cause is found. So to rule out PFO, we use a bubble contrast study as part of a routine transesophageal echo for picking up PFOs.
Again, somebody has asked question like echo in myocarditis and sepsis.
So yes, echo in ICU setting is also done. Our bedside machine, on an average, we do at least around 20 echoes at the bedside, most of them in the ICUs for different indications, including patients being in sepsis, in shock, and we can help you decide about the inotropes and volume to be given based on the hemodynamic measurements by echo. That is a topic in itself. I'll be happy to take a session on hemodynamics by echo because it is very helpful in decision making in the ICU setting also.
Yeah. Pocket echo reliable, sir? There's another question.
Pocket echo is useful for 2D and Doppler only. It has shown to be of value in busy emergency rooms. You can quickly rule in or rule out patients with curly B lines also, if you can see now. Patients in failure, patients having immediately, you can look at the wall motion and you can shift to cath lab with patients undergoing to have MI. And we have picked up a patient with chest pain and we could see a huge gallstone. So that was the utility of handheld echo.
That's great. And anything, Dr. Saab, you have mentioned all about everything, but just I wanted to ask you, ultrasound of lungs in cardiology practice, in acute medical emergencies or in acute emergency. What is
it is becoming routine. It is now an integral part of evaluation of a patient in emergency. Looking at the curly lines by ultrasound, curly B lines as an early marker of a patient in pulmonary edema. It is being routinely utilized in emergency rooms and ICUs.
So thank you very much. If there are no questions, I would say big thanks to you.
Thank you, sir. Pleasure.
Looking forward.
Thank you for the
Looking forward
invitation
to
and
future, yeah.
being part of this discussion forum.
Sure. Thank you. Good night.
Thank you, sir.